We will start with Dr. Ruchi. So, for how many people are doing SICS? Wow, I am very impressed. Very good. So, obviously, we will try our best because we are doing a lot of SICS for many years, more than 20 years. So, we'll try to give our tips and we would love a feedback from you also. So, can we have the question and answer at the end of the session? Yes. That's wonderful. Thank you so much. Dr. Ruchi is assistant professor in the Regional Institute of Ophthalmology, Rohtak, Haryana. She's a very excellent SICS surgeon. So very important for SICS. You can do under topical, but I feel why take the risk of the patient squeezing when you're going to make a tunnel or not? Patients, you can talk to them, they can, and mostly we get advanced cataract with sunken eyes. They are very comfortable with the peribulbar anesthesia or the medial anesthesia. And later on, I will ask, please, for your views also on that. Dr. Ruchi, over to you.
Thank you. A very warm good afternoon to everyone. Myself, Dr. Ruchi. I'll be talking how to give maximum gain to the SICS patient without giving any pain. So objective is to know about the various anesthetic options which are available for small incision cataract surgery. We'll discuss about their pros and cons. We have in the form of topical anesthesia. Yes, they may be topical drops, the intracameral injections, the subconjunctival injections, but they have to be adjunct with all the three together. Then we have regional anesthesias in the form of blocks. The most commonly used one, the peribulbar block. Then we have the retrobulbar. In some indications, we have to use that too, but very rarely. Then we have subtenance injections. And for special indications, we have the general anesthesia. As we know, with the advent of the phacoemulsification, that's topical anesthesia, it's a routine nowadays. It has shifted from the needle to the needleless techniques. Yes, it's fast and simple, but it's, yes, with superficial anesthesia, being needleless, the potential hazards of injections are no more there. But yes, the adequate patient cooperation is a must as there is no akinesia or IOP control. This can be achieved using various eye drop applications, which can be in the form of oxybupiracaine, the most commonly used proparacaine, as it's less toxic to the endothelium, that we can use 1 to 4% lidocaine or the 2% lidocaine jelly. All of know the advantages that it's not interfering with the visual function. There's immediate visual recovery, absence of pain due to the injection, and unlimited ocular motility. But it's difficult for the rookie surgeons. Then to do the small incision cataract, along with the topical drops, we have to adjunct it with the intracameral and the subconjunctival injections. Intracameral, we can use a 2% preservative-free lidocaine. Along with that, the subconjunctival episcleral injection of 0.5 to 0.8 ml of the local anesthetic. Thus, the local anesthetics, they cause the temporary loss of the sensation, analgesia, and akinesia. The anesthetic agent causes depolarization of the nerve membranes. Already discussed the topical agents. And the local anesthetics, they have the lignocaine. The maximum dose is 3 mg per kg. Onset is within 5 to 10 minutes and duration is about 30 to 60 minutes. Bupivacaine, we have the maximum dose up to 2 mg per kg. It has moderate onset of action. Duration lasts for about 75 to 90 minutes. Now, talking in detail about the peribulbar, that is the most commonly used anesthesia for the small incision cataract surgery. It causes complete anesthesia of the globe. It causes temporary loss of the vision due to the blockage of the optic nerve. In some cases, we have to adjunct it with the Vanlet's block to prevent the squeezing of the eyelids. We'll be discussing in detail the technique. I'll show you the video. So here the aim is to deliver the anesthetic agent outside the muscle cone. But yes, we have to be precautious. As more closer the needle tip is to the apex or the back of globe, more rapid is the onset of anesthesia, but more is the danger. We use a combination of these three. Just to revise, that 5 ml of lignocaine with 2% of 1:20,000 ADR. ADR prolongs efficacy. Bupivacaine 0.75%. It prolongs the effect of the anesthesia, and to permit its diffusion, we use 75 units of the hyaluronidase injection. So the commonly used sites are the inferotemporal, followed by supranasal, and that can be, in spite of supranasal, we can use the medial blocks. So this is the video showing the how to give the peribulbar. First of all, after instilling 2-3 drops of the topical anesthetic drops like proparacaine, we need to clean the patient with povidone iodine solution. Then, as you know, povidone is the best antiseptic. It is both antibactericidal, fungicidal, and even acts on the viruses. Now, we have to first give instructions. We should try to decrease the apprehension of the patient. He will give you an injection that will cause a little bit of pain, and we have to ask the patient to fix the gaze in the straight gaze, straight direction, straight neutral gaze. Then after palpating the lower margin, at the junction of lateral 1/3 and 2/3, we have to use a non-dominant hand to make a space. We have to keep, here the precaution is we have to keep the bevel of the needle. That is most important. We have to keep the bevel towards the globe, and we have to take the needle slowly along parallel to the orbital floor. Then yes, the most important always this thing always draw the needle back to prevent the inadvertent intravascular injection of the local anesthetic. Otherwise, it will lead to the hell of the complications. So we have to press it with the Hornets ball, and then we have to give the additional secondary block, secondary injections, which is in the supranasal direction. Then we have to, before giving this pressure with the Hornets ball, we have to make it sure that the eye is closed. Otherwise, it can lead to the epithelial abrasions. We have to give the pressure with the counting of 1, 2, 3, 4. Then we have to release. It decreases the chemosis and helps in early spread of the local anesthetic, which brings the block at the faster rate. Now we need to know what are the relative contraindications. Patients who are on anticoagulants, we have to stop at least 1 week before. Patients who are blind in the contralateral eye. Patients who are not able to lie still during the procedure, and the patients with open globe injuries. They are the relative contraindications. Discussing a bit about the complications of peribulbar, there can occur the central spread of the anesthetic, which can lead to the life-threatening complications resulting in the signs and symptoms of bradycardia, cardiac respiratory arrest, but it's very less common with the peribulbar blocks. Then the dreaded one, the globe perforation, because even with the immediate recognition, the visual prognosis is poor. So it's more common in the myopics with elongated globes, with staphylomas, use of the larger needles. There's a poking through sensations while placement of the needle. So you have to be very slow while placing the needle. If there is one may notice the sudden absence of the red reflex, either the excessively soft eye or excessively hard eye, because of the injection of into the eye. So in order to avoid this complication, we have to ask the patient to look in the primary gaze. Needle should be straight. In longer eyes, we should first check what is the biometry readings, what is the axial length of the eye. If it's longer, we should prefer to use 26 gaze needle. We should try to make the space between this orbital rim and the globe, and we shouldn't move when the needle is inside. And if you ever feel that there is a resistance while you are injecting a local anesthetic, then you should stop at that only. The Hyaluronides, it has the benefit. It allows the local anesthetic to spread more easily, thus reducing the concentration of the anesthetic agent around the extraocular muscles. Otherwise, it can lead to the direct damage to the extraocular muscle or its nerve, leading to myotoxicity with the effect of prolonged diplopia. There can occur oculocardiac reflex, which may manifest in the form of bradycardia, nodal rhythm, AV block, cardiac arrest. It can be due to the direction extraocular muscles, or due to the manual pressure on the globe, or due to the ocular manipulations. We have to stop stimulation by that time and have to give atropine 0.01 milligram per kg by IV route. Then there may occur this venous orbital hemorrhage or arterial. There occurs there is slow proptosis with the visible bruising of the lids and subject conjunctival. We have to stop that. If it is due to arterial, that has faster onset and it has more pressure, then we need to reduce the pressure either by doing the lateral canthotomy or the orbital drainage, and the surgery has to be postponed and the eye need to be protected. So why we prefer it peribulbar or retrobulbar? Because there are less chances of retrobulbar hemorrhage, less chances of perforation or injury to the optic nerve, and less chances of deposition of the anesthetic agent inside the muscle cone. Talking a little bit about the subtenuous injections. Here the most commonly used site is the inferonasal conjunctiva. This we give a 2 to 3 mm incision into the conjunctiva halfway between the inferior limbus and the fornix to open the subtenuous space. Then we either put a blunt cannula or directly insert into with the needle. So it covers the muscles and nerves within the cone. Like we have some special indications of the general anesthesia for the uncooperative mentally retarded who cannot who are anxious, uncooperative psychiatric patients. Here we need to give the general anesthesia, but it has its own complications. Thus, I just want to give the take-home message that no local anesthetic is entirely free of the severe systemic adverse effect. That all local anesthetic agents are myotoxics. Prefer to use the short ones, fine needles. Ask the patient to look in the primary gaze position. Gentle aspiration should be done before injecting the local anesthetic. And bevel of needle, these are simple ones, should be facing the globe and should be tangential to the sclera. Thank you.